chosen by the IPEG board from...
Shout out to all of you who are here on this last day and especially on a Sunday morning. So I'm Anna, I'm a PhD student at Sebastian Albrecht's lab, and I'll be talking about a marker for non-response following ketamine or S-ketamine treatment and treatment-resistant depression. And I'm sure, as most of you know, treatment-resistant depression is a very debilitating condition affecting around 42 million people around the world. It's associated with increased direct and indirect costs, but more importantly, it's also associated with a very high psychological and humanistic burden. So we see higher mortality rates, especially due to suicide. On average, 25 years lost to disability in the context of treatment-resistant depression, and also very slim chances of achieving lasting remission in these patients. And this is actually why I thought this quote from a qualitative study was very fitting, where depression was described as a kind of being trapped as something very narrow. And interestingly, when you now look at this quote from another qualitative study on the subjective experience of S-ketamine treatment in treatment-resistant depression, it also kind of fits well because S-ketamine was described not necessarily as a magical cure, but as something that's able to offer a lift of these symptoms. And randomized controlled efficacy trials tell us that this lift usually occurs rather rapidly, so usually after a single administration and within 24 hours. And we can also see lasting improvements during maintenance phases. However, if we then look at real-world effectiveness studies that are, by definition, not conducted under these very controlled conditions, so you see usually a more diverse population in these studies, we can see response rates as low as 30%. And also what we see is that some patients will only show a response after several weeks of treatments, which actually contradicts this initially assumed rapid onset of antidepressant effects. And this is why we believe that using as much information as possible to decide if a patient should receive ketamine or S-ketamine treatment or not is really pivotal, especially when we know that the chance of achieving remission actually decreases with every additional failed treatment attempt in treatment-resistant depression. And of course, relying on data that is already being collected as kind of the standard clinical routines like EEG or ECG data offers an additional advantage when we, in terms of clinical translation. And Sebastian already briefly talked about the study that was conducted by Cheng, who's already on her way home, I think, and also a few other familiar names and faces from the audience today. But just to quickly recap, what they did was they worked with patients with major depressive disorder and basically looked at the predictive value of EEG vigilance to predict response following a single dose of intravenously applied ketamine. And response was defined as a 33% reduction in Montgomery-Åsberg depression rating scores from baseline to 24 hours post-treatment. And what we saw was that a higher percentage of vigilance stage A1, so one of the higher vigilance stages characterized by predominant alpha activity in occipital brain regions, was associated with treatment response. And even more specifically, applying or using the optimal cutoff at 43% of vigilance stage A1 yielded an accuracy of 67% in the testing data set. So in plain terms, what this means, if you have a patient with a major depressive disorder and they will exhibit 43% or less of vigilance stage A1, they will be less likely to show a response to intravenous ketamine. And typically in like a clinical setting, you would never just apply a single dose of intravenous ketamine, but you would administer it for several treatment sessions. So we wanted to replicate this finding in a real-world clinical context. And at the University Hospital of Psychiatry, between 2021 and 2024, 54 patients were treated with S-ketamine or ketamine, and they received the treatment intranasally twice weekly for 4 weeks, and then once weekly for another 4 weeks. And for this analysis, we ended up including 46 patients. This wasn't because we had any specific exclusion criteria. These were just the patients of whom we had complete pre- and post-treatment measurements, including the IPEG depression inventory, the Montgomery-Åsberg depression rating scale, and at least 3 minutes of EEG resting state recording pre-treatment. And we also worked with a subsample of these patients consisting of 23 patients of whom we had 10 minutes of resting state EEG data. And this is also the reason why we work with these 2 different response criteria. So we had the 50% response criterion for the 3-minute sample and a 33% response criterion for the 10-minute sample. First of all, to more closely align with the original study, but also to simply increase the rate of responders we had in this 10-minute sample, because as you can see, about 2/3 of patients did actually not show a response to ketamine, even when applying this lower threshold for response. Now, when we look at median vigilance, so the trajectory of vigilance across the recording segment, we did not observe any significant differences between the responders and non-responders in neither the 3-minute nor the 10-minute sample. Just on a very, very descriptive level, so this is not statistically significant or anything, but potentially distinctive features of the responders, especially in the 10-minute sample, is that you can see that they have a very, very rigid pattern of vigilance with a complete lack of up or down regulation of brain arousal. And this is even more apparent when we look at the individual trajectories of these patients. So you can see here, one patient completely rigid, another patient from the response group completely rigid, and also this one here. When we now look at the percentage of individual vigilance stages, we did observe significantly lower percentage of stage A2-3 in the responders, significantly higher percentage of stage B1, and we also saw C stages, so sleep stages essentially, in the response group in this 3-minute sample. We did not see any significant differences in the 10-minute sample, although, again, on a descriptive level, you can see that responders do seem to show a higher percentage of stage A1, which is actually what we would have expected for the sample to see. Now, bear in mind, these are really just group differences. This does not necessarily mean that they hold or do not hold predictive value. And again, the primary goal of this analysis was actually to replicate this 43% threshold. So we applied this to our sample and looked at how well it performs in predicting response, or more specifically, actually non-response in our sample. And what we saw for the 3-minute sample, that it achieved an accuracy of around 76%, quite good sensitivity at around 80%, less optimal specificity at around 25%. And while the accuracy seems to be quite good if you compare it to a stratified random prediction, so random prediction, but considering the ratio of non-responders and responders that we saw in our sample, we can see that it does not really add any additional predictive value. However, if we now move on to the 10-minute subsample, we observed even higher accuracy at around 78%, very, very high sensitivity at 94%, again, for predicting non-response, and less or lower specificity at around 33%. And also, when you look at the comparison between to the random prediction, you can see that the marker actually adds predictive value. And maybe to quickly summarize again in plain terms, this means our marker seems to perform quite well in detecting non-responders, not so well in predicting responders, which essentially means that we, by just relying on this marker, that we will also have a very high, or not a very high, but a substantial proportion of patients that we will falsely classify as non-responders. But going back to kind of the clinical setting, this is not really a disadvantage. And I'm also thinking about Nikita's talk, and I really liked her takeaway that even if you're wrong, you're right, because the decision we make is not should this patient receive esketamine or no treatment at all, but it's should this patient receive esketamine, or should we maybe start or continue with a different treatment first. So what we are suggesting again is to really use as much information as possible when you, for example, trying to decide between 2 or more equally valid treatment options. And the additional advantage we have is that you never rely on just one marker, right? So you have an array of different information sources you can use to really make this informed treatment decision. And this analysis was conducted using the DeepSci pipeline. So this really offers a fast and unbiased way to analyze EEG and ECG data. So just to give you an idea, it took me about 5 minutes per EEG recording to really get this very nice report here. You can also ask us if we still have reports left, so you can see it a bit more closely. And as you can see, it doesn't just give you one marker, but it gives you an array of markers that you can simply use to, again, make this informed treatment decision. Okay, that already brings me to the end of my talk. Thank you so much for listening, and also, of course, big thanks to my team. Thank you.
Thank you for your presentation. Are there any questions? Short questions.
Thank you. Very nice presentation. My first question is about the route of administration. How does the intranasal administration compares to the, let's say, IV administration of the same compound in terms of efficacy?
Yes, that's a very good question. I think I'm honestly not an expert on that, but I think the bioavailability for intranasal ketamine is slightly less than the intravenous one. Are you asking for a specific reason, or are you?
You mentioned that it's not very effective when you administer the esketamine.
Yes, I mean, yeah. Yes. The truth is that when you look at intravenous or effectiveness studies for intravenous ketamine, you can see quite similar response rates. So I think it's not necessarily the compound itself that's less effective. It's more that it's less effective in a real-world setting compared to, again, these very controlled studies where you, for example, include patients exclude patients with substance use disorders. You often exclude patients with personality disorders and so on, and all of this affects your response rates.
Thank you. My second question is a methodological one, and it might be a quite naive question. Why do you make such a short recordings, like 3-minute sample and 10-minute sample? Why not longer ones?
Yes, I would have preferred longer recordings. So I think 10 minutes is ideal for us. So the DeepSci report relies on, or not relies on, but like the standard recording length is 10 minutes. But this, I didn't do these recordings. So these are clinical EEG recordings. And especially with like very high burden patients, it's sometimes not really possible to do even like a 15-minute EEG recording, even if that seems very short to us. And also it just doesn't necessarily have like the highest priority in a clinical context. So our clinical EEG specialists at our clinic, she has like, I think, 20 patients per day, and also patients have other visits or other treatment sessions they need to attend to. So the EEG sometimes falls short. Yeah.
Okay, one more question, very short.
Yeah, thanks so much. Again, it's so great to see objective evidence being used to provide concrete recommendations that could help people.
Thank you.
Today with existing, therapies. That's amazing. On the measurement of vigilance, I'm not an expert on it, so excuse if this is a naive question, but to what extent is it affected by day-to-day variability in people's mood or caffeine intake, or how well they slept the night before, or sleep patterns in general? And especially if you're talking about 10 or 15 minutes, and I'm assuming it's eyes closed, do people not just fall asleep? And yeah, how do you can you control or any of those confounds?
Yeah, that's a very, very good question. So we refer to vigilance as a state-regulated trait. So we think that there is a trait aspect there, but that it's affected by the state you're in. It seems to be very robust against things you mentioned like caffeine, also to a lot of the medication. It seems to be quite robust. The other thing you mentioned regarding sleep, that's actually, they are allowed to fall asleep, so we do not control them in that way, and that's also part of the instruction. So we tell them, if you fall asleep, that's completely fine, because this is actually exactly what we want to measure. And also going back to Sebastian's talk on the first day, this is actually what we see in, for example, patients with manic symptoms or ADHD, that they will actually fall asleep during these 15-minute recordings. Yeah, but we do have to manually classify these sleep stages. Yeah, that's a good question. That's not usually an issue. I mean, I don't know about you, but if I have a bad night's sleep, this doesn't necessarily mean that I would fall asleep if someone just lays me in a chair and puts an EEG on me and all of that and tells me you're allowed to fall asleep. I don't think I would fall asleep, and I think most of us wouldn't fall asleep. So it's not necessarily affected by that. But yeah, very good question. Thank you.
Okay, thank you for the discussion. Thank you once more.